Oh, hello, everyone, and welcome to another edition of NextGenMD. I'm with Dr. Lily Johnston, amazing vascular surgeon from Southern California. She has a private metabolic practice. Also, she works out of Scripps. She's a vascular surgeon there. And today, I'm so excited that we are talking about poop. Yep, you can naturally lower your cholesterol. My dad is proof. He was told that he didn't have a liver production problem when it came to cholesterol. He had what was called a cholesterol reabsorption problem, and his doctor told him that he needed to poop more. I am not kidding, Dr. Johnston, but that was in the cardiologist and the dietitian's language that he needed to poop more. So the two of them worked together. They got him on some plant sterols, improved his fiber in his diet, and he was having bowel movements 2 to 3 times a day. And he saw a dramatic decrease, not just in overall cholesterol in his basic lipid panel, but also in his advanced lipid panel. The particle numbers dropped. The explanation they gave to me, and I am not going to be clinical about this because this is the way they described it, is that the HDLs carry the LDLs out. And if you're not pooping enough, then they get reabsorbed in your body and continue to circulate. So the more you poop, the lower the cholesterol, at least in his case. So I'm curious your thoughts. And the reason this comes to mind today is because I was seeing advertisements on Facebook for what's called Step One Foods. And there is a doctor who says that her particular food items are clinically proven through a study at the Mayo Clinic to lower cholesterol naturally. So I will give the floor to you for your initial thoughts to get us starting in this very interesting, I think, conversation.
Thanks for bringing this up, Kim. It's a really interesting place to take a deep dive. And to a first approximation, the premise is correct. We do excrete cholesterol, especially in our bile. So bile is that green stuff that the liver makes, and it helps us digest our food. And one of the key components in bile salts is actually cholesterol, but it's a valuable substance, and the body thinks, well, it's kind of expensive to make this stuff. Why would I make more of it? Why wouldn't I just reduce, reuse, recycle what we've already made? So there is a pathway in the intestine to reabsorb the cholesterol bile salts. And we do also absorb cholesterol, sterols, and stanols from the animal and plant foods that we eat. And those are absorbed through, I'm going to get super nerdy here, something called the Niemann-Pick 1-like-1 receptor. And so there is absolutely an absorption from things that we eat. There's also reabsorption from cholesterol that we excrete and reabsorb, recycle, so that the body doesn't have to keep making it over and over again. The general premise behind excreting more is to build up basically a big gel layer, a big glob in the intestinal tract that traps both the bile acids and any other cholesterols or sterols that we might have in our diet, so that they just pass through the system instead of getting absorbed. And that is the key mechanism behind things like beta glucan, which is oat bran fiber or barley-based fiber. That is one of the key ingredients in that supplement product that you mentioned. The other one that gets talked about a lot, which isn't in that particular product, but that also has clinical application in reducing LDL-C, is psyllium husk or psyllium. And that is another type of fiber that can absolutely also reduce LDL-C 8 to 15%, depending on the study, sometimes a little more. When that is taken. And again, it forms this gel matrix, for lack of a better word, in the intestinal tract and prevents what we eat and those bile acids from getting absorbed. We can talk about plant sterols in a second. That's a different mechanism, but let me stop there and let you process that to start with.
Wow, that's a lot. And I imagine that it was interesting because my dad's he went to a second cardiologist And we talked about, I said, I couldn't believe this. All he has to do is increase his bowel movements. And the doctor says, I've never heard of such a thing. This was a second cardiologist. So this isn't widely known, which is surprising to me, that this can definitely help. And so I went to, just earlier today, I went to a bunch of our patients and I said, has your doctor ever talked about improving the number of times that you're using the restroom? Not once has it ever came up, but yet you know about it. But of course, you're on the cutting edge. You're all about metabolic health. You're all about trying to find different ways naturally to help patients to improve their cardiovascular and vascular health. What is taught? When you are in medical school, what is taught about this?
That's actually the start of a much longer,
Oh,
fairly depressing
yeah.
conversation. I would say, most of what is taught in medical school about nutrition takes maybe 4 to 8 hours. And that's in a classic program. There are some other places that have, a culinary medicine elective or might have some more
Mm.
in-depth approaches. So I don't want to paint everybody with the same brush, but classically, most doctors are getting 4 to 8 hours of nutrition, and a lot of it is based on vitamins and like the big vitamin deficiencies that we get tested on. So vitamin C, what does vitamin C do? It makes the helps with proline and collagen formation. Well, what are the vitamin C deficiencies? It's scurvy. Why does that lead to bleeding gums and hair falling out? Because of the collagen problems, right? So it's in a, B vitamin deficiency and wet berry and dry berry and thiamine, all these things, right? So we also have those vitamin deficiencies, and there is a sort of general throwaway, sort of Michael Pollan based, like, eat real food, not too much, mostly plants type of an approach that says, you all know what healthful eating is, right? Like, do that and tell your patients to do that, without any acknowledgement that that has not been working very well for us for the last, I don't know, 50 to 100 years, as rates of diabetes and obesity and heart disease and all of the chronic illnesses seem to keep going up and up. So nutrition is a low point, I would say, of current medical education.
You know where I'm going to go with this conversation as soon as we talk about the plant sterols. Because I want to know exactly what these plant sterols are and how they work. But we talked about the fiber combined together. The step one foods. This cardiologist that started that company said that combined in her meal plan, it can literally and has been clinically proven to lower cholesterol. I'm curious, why would these pharmaceutical companies not take that approach in lowering cholesterol? Or have you seen statins that have a little bit of the same mechanism of action?
It's not statins, it's ezetimibe. Ezetimibe does use this pathway. So it prevents absorption in the intestine through the Niemann-Pick 1 receptor. So we absolutely have a pharmacologic target. The other thing to really point out is what the degree of lowering is, because it's not profound. So the study that you mentioned to me, the randomized trial that was done of this supplement food, showed an average of about 9%. Sorry, my lights went out. 9% LDL-C lowering.
Yeah.
And if your patient started, the average in that study was 130 milligrams per deciliter. So for our patients with PAD, who we want at a goal of less than 70 or maybe less than 55, this isn't going to cut it, not by itself. It is not a substitute for those drugs in those patients who need a much lower level. Now, if you are a primary or primordial prevention patient who never wants to develop cardiovascular disease, and you have been told that you have elevated LDL and you want to take every path besides medication to get that down, by all means, let's talk about some of these strategies that can be used to do that. And there are several, right? We talked about the soluble fiber, which is beta-glucan-psyllium. That's one, and it's probably among the more powerful. And we talked about reducing absorption, and that's part of it. What that ultimately does is actually upregulate the LDL receptor in the liver, which then pulls more of the cholesterol or the LDL particles out of circulation, which is why we end up seeing better numbers. So that's ultimately how that turns into lower LDL-C. And we can talk about some of the other other things that some people try. And some of this depends a little bit. Again, you mentioned your dad doesn't have a synthesis problem, which is, liver synthesis of those particles. He has an absorption problem. And so we have this balance in everyone, and it's a little different depending on who you are. And people call this, cholesterol balance. That's from the Boston Heart test. But we can measure sort of the degree to which you are either overproducing from the liver or overabsorbing from the intestine.
That's interesting. You mentioned Boston Heart. So that's exactly my dad's cardiologist and dietitian were really into Boston Heart diagnostics. And actually, our chief medical officer, Dr. Michael Danziger, was their chief medical officer for a long time before he just recently left a couple of years ago to restart his diabetes reversal private practice as well. But that's where he got the cholesterol reabsorption test. But what was even more interesting is just a couple of days ago, he was having it turns out, just some indigestion. But what we thought was indigestion back in 2019 turned out to be him on the verge of a heart attack. So we're a little bit sensitive. So we sent him for a PET scan just this week, actually, on last Monday, a week ago. And the doctor said, I cannot believe this. He was having an 8% year-on-year growth in his plaque for several years. And up until about 2 years ago was his last heart cath. He had an 80% narrowing of his LAD, several stents placed. And he just had this PET scan, no sign of ischemia. All the stents are completely opened, and he has a 63% ejection fraction. He's doing absolutely phenomenal. And the doctor said, what have you been doing? And I said, well, let me find that bottle of plant sterols he's been taking and the fiber that he's on. I mean, it's amazing that this can work. He is not on a statin. They put him on one initially to get him over the hump until he proved that he would follow through with his lifestyle modifications and better diet and supplements. And he's doing absolutely amazing. All of his cholesterol numbers are normal.
That's outstanding. Congratulations.
Right. It doesn't mean it's right for everyone. And we do see these conversations across the web where patients don't want to take cholesterol and they're advising each other to not take the statins, but there are reasons to still. And if you go to our YouTube page, youtube.com/the way to my heart, look under the NextGenMD playlist. And Dr. Lily Johnston has an incredible array of video discussions on statins, when they're necessary, why they're necessary. And even the doctor that founded this Step One Foods was saying a diet is not a complete replacement for statins, that there's still a major role that needs to be played for statins. They may be able to, in some cases, be weaned off if the diet is working effectively, but you still need, as you said, you need those statins to get that, patients over the hump and get that significant lowering.
Yeah. As we talked about in those other videos, this is always personal choice, right? Necessary is one word. I would say what I would recommend based on guidelines is the other way to phrase that. And patients like your dad are always welcome to make their own choices. And I feel compelled to support them and do the best we can with what their frame of reference is. And some people want to be on meds and tolerate them well and don't have any issues with it. Great. Other people say, not for me. Willing to take the risks of not being on the meds to avoid the risks of the meds. Fine. Let's use other approaches and just be aware that no trial of lifestyle-based reduction of LDL-C, other than Predimed, which was not really a cholesterol lowering, but these other types of, fiber, for example, and plant sterols, none of that has ever shown a reduction in events, meaning hard outcomes like heart attack, stroke, or death. We can show reduction in LDL-C, and based on the large body of data that shows kind of a linear reduction in events with a linear reduction in LDL-C, we would expect probably a 6 to 8% reduction in events based on this, 8 to 15% reduction in LDL-C. But it's not the same as the PCSK9 inhibitors, the statin therapy, when we are truly driving LDL-C below that 55, some people are even saying 40 milligrams per deciliter to really reverse plaque. We're not going to get there with lifestyle. And if you have arteries that are on fire with active heart attack, stroke, limb loss scenarios, I would advocate for trying to drive down that burden of fuel for the fire, at least in the acute phase. And unfortunately, psyllium ain't gonna do it.
No, I mean
But
we're talking about arteries. You nailed it with arteries on fire. We're talking about inflammation in the arteries, and one of the lesser known, um, for patients because it's not really talked about, is that the statins actually lower the inflammation in your arteries, and that is really one of the main driving factors for it, right?
it is, and that is not something, for example, that we saw in the use of this supplement. To my understanding, having not gone through the trial in excruciating detail, but there was LDL-C lowering. I do not think there was any change in high sensitivity C-reactive protein, although patients may not have had elevation in that at baseline. But yeah, we didn't see any real change in inflammation. When we transition patients from a highly processed, highly inflammatory nutritional strategy to one that is whole food based and less inflammatory, certainly we hope that those inflammatory markers will come down, the overall inflammation will come down. But let's stick on this for a moment because it's actually relevant to the conversation about plant sterols. So plant sterol, which is another active ingredient in this supplement and something that has also been advocated for in the cardiology space for a long time. And you'll see it in things like margarine and sort of the butter replacement spreads, all the vegetable oil spreads that people have advocated for. Those are plant sterols and stanols, and they compete for absorption with the other sterols and stanols, or like the animal-based ones and our own. And so they replace them. If you think about what you're doing, it's now a cholesterol that we don't measure. It can also be oxidized. And there is some evidence that, especially in hyperabsorbers, and especially the worst case of hyperabsorption, which is something called cytosterolemia or cytosterolemia, those particular patients may be really adversely impacted by plant sterols. They tend to have accelerated atherosclerosis when plant sterols are provided. And that does not seem to be a large proportion of the population. There's not a danger signal as we look at population-based research for this. But if you think about, or if you listen to some of the, lipidology key thought leaders in the space, people like Tom Dayspring, there is this kind of reservation about using plant sterols widely, especially in people who are hyperabsorbers. They may not actually see that much benefit, even though it lowers the LDL-C. They may actually have oxidized plant sterol products that contribute to atherosclerotic progression in those patients. And certainly patients with cytosterolemia will accumulate a large number of sterols and have premature atherosclerosis that is severe, and they should not be given plant sterols.
Oh no. Well, I'm glad my dad wasn't one of those.
Yeah, me too.
How do you know?
Well, again, if you have hyperabsorption on a cholesterol balance test, I would probably stay away from plant sterols. But the other thing would be to look at the broader picture and say, what causes oxidation? Oxidative stress is caused by things that are inflammatory. So if you have HSCRP out of control, then I probably wouldn't put anybody like that on plant sterols because of the concern for oxidation, if there are other options that we can use to lower LDL-C. And again, we have so many options in our toolbox. For me, I'm not super comfortable with that. And that is my own personal stance. It is not based on a strong base of evidence. But I feel like, again, we have so many other tools that seem safe and appropriate that I'm not sure why I would want to take the risk of oxidizing the plant sterols. And I know the European folks have expressed some reservations about it. Again, no evidence that it has ever produced a reduction in cardiovascular events. So I'm sort of cautious about them. In, again, our large population-based studies, it doesn't seem to be harmful. The U.S. cardiology community is pretty pretty in support, I would say, of the sort of plant-based oils and fats that might replace animal-based oils and fats. Fair enough. Not my own personal first choice.
It's interesting. I mean, every single one of these, I'm looking at the ingredients, and the key ingredient, I mean, if you're looking at the list of all of the ingredients, most of them you recognize, but in every single one, it just in general it says plant sterols. And I'm not sure exactly. I mean, that's a little concerning that we don't know exactly what they're using. What does that
Yeah, I mean,
mean?
and
Because
the stanols are actually less likely to get oxidized than the sterols, I think. And again, we just don't know. So it's probably fine, might be good. I am not totally convinced that it's the best choice. I think that the evidence for things like psyllium and beta glucan is much more compelling to me personally. But there are plenty of preventative cardiologists who would freely disagree with me, and that's okay. And again, I think in the general population, I am sure that it's reasonably safe, but I probably wouldn't do it for myself personally.
I think for the most part, it's $125 for a starter pack of
Wow.
these,
How long does that
and
last somebody?
1 month.
Okay.
That's what it looks like. And so for those, I would imagine if we have a similar, set of patients, I would imagine that so many patients would not be able to afford $125 a month. I think some of the ideas for ingredients, I mean, you can get a lot of these, right in your local supermarket. Oat bran chia seeds, flax seeds, dried cranberries, um, almonds, walnuts, raisins. I don't know what Saskatoon berries are. It's in quite a few of their products. I'm wondering if those are sour berries. Also in this one, there's whole oats, dried blueberries. It's interesting though. I'm worried a little bit about the sugar especially for diabetics in here. They use apple juice concentrate. The dried blueberries, the dried cranberries. Usually, dried cranberries have there's cranberries and apple juice concentrate again. They're also using seed oils. I'm not the biggest fan of seed oils. They're using sunflower oil. But then there's the same almonds, walnuts, chia seeds, plant sterols again, cinnamon, and then the Saskatoon berries. I will have to Google that one. But also raisins. So, I mean, it just seems like certain things that our chief medical officer, Dr. Michael Danziger, does not ever want our patients who are diabetics eating dried fruit.
Yeah, and I think you have to ask yourself for each individual ingredient, what is the evidence that it's being beneficial or that it's helping, right? So, that product has the flax and the chia are to provide ALA or a precursor to the omega -3 fatty acids, EPA and DHA, which is typically used, provided in either fish oil or krill oil. The ALA, the plant-based versions of omega -3 acids, are not very efficiently converted into DHA and EPA. They may have some ancillary benefits, but if what you're trying to get is the beneficial effect of EPA and DHA, maybe I would go to that directly. And there was no change in triglyceride levels in that trial. If that's what you're using that for, maybe use
Mhm.
icosapent and the sort of prescription formulation that has been shown to improve outcomes in patients with elevated triglycerides. But if what you're after is LDL reduction, you don't really think that the omega -3s are going to help you there. So, do you need that? The next piece would be the sort of antioxidant or polyphenol based component, all the berries and things. Everybody likes the idea of polyphenols. And in large observational trials, people who eat more, quote unquote, of the rainbow or the highly colored fruits and vegetables seem to have better health outcomes. But we don't know for sure that that's really related to this. I've not seen compelling evidence that results in LDL-C lowering, and whether it truly results in reduced oxidative stress and inflammation. To me, I think that's a little bit on the fence, especially if it's coming in the form of high glycemic components like dried fruits that may have some added sugar in them, even with the fiber alongside of it to delay the absorption. Is that really your best bet? I don't know.
I mean, I'm even just looking from a cost standpoint. My dad's plant sterol that he gets is $29. You can get them anywhere between 25 and $55 for a 3-month supply. And that might be if your doctor says that plant sterols are right for your situation, your presentation of disease, and there isn't any risk in your situation. Having that along with eating your walnuts, your almonds, adding the chia seeds, some flax seeds if you're not allergic to them. I found out I'm allergic to flax seeds. I was
Ooh.
thinking, who is allergic to flax seeds? Me. Um, it was just one of those fun add-ons to the allergy test. I
Ooh.
was right. And I thought, I have them every day, no problem. Yeah, between that and zucchini, my number one and number two. Yeah, that was great. Two of my staples. But it just seems, and also adding, some psyllium husk. I've never looked up how to order or incorporate psyllium husk into my diet, but I imagine you can get some sort of powder to
Yeah, I mean,
sprinkle.
Metamucil is psyllium, right? It's standard, regular old Metamucil. It's pretty cheap and easy to find.
You can sprinkle that into any smoothie if it's okay with your dietitian or nutritionist.
It'll
And it's
get
a
it'll
little
get
bit
super gummy. So if you do it right at the end and put it down the hatch quick. Otherwise, it gets really gross.
from personal experience.
Yep.
Oh my goodness. So that was really interesting. I'm so glad that we could have this discussion about this because we see this kind of stuff out there on, especially on Facebook with its Facebook ads, Instagram ads, and now with a lot of these companies going direct to the influencers that have no medical experience, that they just have a very large following. They're really good at putting together videos, viral videos that are fun to watch. And you watch them just eating this stuff down, and you're like, oh my gosh, this seems so much better than taking a statin. I'm going to do this instead. But you really have to take a step back. You can't believe everything you see. And some things, such as in this case, might be helpful, but it also might be harmful for you. Your life is on the line. And yes, you can try it, but you should have the conversation with your doctor.
Yeah, and measure something, right? Make sure that you're getting your labs done before you start, after you've been on it for a few months, so that you can decide if it's effective for you. I don't mind anybody having the desire to run this experiment for themselves, to play around with certain interventions. I think that's a great approach and it allows everybody to feel in control. But let's just do it with data and make sure that we're watching to see, is there progression of plaque, is there a progression of an ABI, whatever we're following over time. Let's just do it with data. And that's what I love about your dad's story is, he's made a decision and now we have follow-up information that says, yes, this is an okay, excellent path. His clinical picture is improving, his imaging is improving, his cardiologist is super pleased.
Yeah.
So while it's probably not the choice we should make for every other patient, for him, it's working. And really that is my goal as a doctor, is to pick what will work for my patients, both personally with their value set and medically, to keep them healthy in the long run. So
Yeah. I mean, I think something like Step One Foods, I love that you mentioned in the beginning that this is something that is great for a preventative measure. This is something that if you know that you're at risk, maybe your cholesterol is starting to inch up, right? It's something to try and lower the cholesterol, but you should also make sure that you're measuring the inflammation in your body, because there is a concern, as you said, with those plant sterols becoming oxidized and the harm that it can do to your body.
yeah, and I believe that this supplement is probably based on something called the portfolio diet, which again incorporates nuts and seeds, mostly a
Yep.
plant-based approach. And again, what I don't want is for somebody to have kind of a garbage nutritional strategy to be like, oh, I'm going to eat these muffins and that's going to fix everything, right? There's always this temptation for all of us to like see if there's a lower investment option to like do hard things. Like I don't need to exercise, I'll just buy the shaker plate. I don't need to change my whole diet. I'll just add these muffins twice a day that are $130 a month, and that'll be enough. And I would caution again against the sort of influencer culture that says this one supplement, this one hack is the solution for your chronic disease. It's probably going to be less exciting and less sexy than that. It's probably going to be long-term changes in your nutrition and your exercise and your sleep and your stress. And it's going to be harder than you want it to be, but it's also going to be more effective in the long run. So,
and the Mayo Clinic did, there were researchers that did a study on the one-step foods, and they said, yes, it did lower cholesterol in this subset of patients, but also the doctor on there is saying that it's not a replacement for statin therapy for most people. Now, it could be adjunctive to statin therapy, and it could be something that over time it can help you wean off of statins if that's appropriate in your situation. But of course, you still need to talk to your own personal doctor to make sure, to see what's right for you. And as Dr. Johnston says, show me the data. Get the data before you do anything. Get the measurements, not only of your cholesterol, get the particle number. And then on top of that, also the triglycerides, but also make sure that you do have your CRP. And I even think, what do you think about LPPLA2? I know that's a little expensive and not all insurance covers it, but that was really helpful for my dad. The MMP9, I think it is the enzyme that is usually
yeah,
present in.
MMP9 is interesting. I don't know how to intervene with MMP9. LPPLA2, I think, I've measured it quite a bit in my patients, and somebody told me at this at a meeting once, and I think he's probably right. It seems to correlate very strongly with LDL particle number. The more particles we have, the more leukocyte-related inflammation, vascular inflammation we will have. There's more availability for phospholipids to be oxidized. So probably those are tracking, and so I'm less insistent about measuring LPPLA2, although I do find it helpful to help some patients see that even though their CRP is normal, they do have significant inflammation in the vascular space. And that is sometimes worth demonstrating to them, because I've had some people with normal HSCRP, like, I don't have any inflammation. Like, well, your vessels look pretty terrible and your LPPLA2 is elevated. So it's very focal inflammation, but it's there. That may be worthwhile. But I don't think I need it for every patient to kind of make good decisions going forward. So I think it's a nice to have, but not a must have.
But it can also let you know if there's someone that has, a lot of it is the damage to the arteries, right? There's something damaging
Yeah.
the arteries that is leading to it. But also, when it comes to oxidation, I would love for you to just, when you talk about, the oxidation and these particles becoming oxidized, is that from the trans fats and the free radicals, just as an example?
Yeah. I mean, it's one of several examples, but sure. And it speaks to this general idea that, I speak about this in another video I have coming up on my channel too, but think of LDL particles, ApoB particles as trees in a forest. Do you have to have a forest for a forest fire? Yes, you must have a forest to have a forest fire. Do you blame the trees for burning down in a forest fire? Probably not. Is the way to prevent all forest fires to cut down all trees all the time? Probably not. Can you modify the environment that the trees are in so that it is more humid and there's more rain and there is more lush tropical vegetation so that it is less likely to catch fire? Yes, you can. And our sparsely populated forests, so anyway, this metaphor can carry on for ages, and I won't belabor that point, but LDL-C is relevant to the progression and formation of plaque, but it's not the spark. It is not the lightning. And the environment that we have in our bodies related to our insulin resistance, to our inflammation and oxidative stress, from our, hypoxia from sleep apnea, cortisol from chronic stress and trauma, all of these things contribute over time to the stress on our bodies, in our vessels. And if the LDL is circulating, yeah, it will show up there to form plaque and heal that injury. But if we can control the mechanism of injury first and get ahead of that, then we have to worry a lot less about that LDL-C. So this is why in the primordial prevention population, we focus so much more on the metabolic risk factors that contribute to injury that then cause plaque, because, fixing LDL-C in somebody who has rip-roaring diabetes who still has an A1C of 10, like that's not protecting them against a heart attack or a stroke. I mean, it's a little bit protective, and I'm not saying don't do it, but we're missing the point. Like we're not really addressing the biggest elephant in the room in terms of their risk. So, yes, again, our guidelines suggest that we should add statin therapy to patients who are diabetic, but let's manage the diabetes. Let us figure out why they are insulin resistant and try to get that under control and prevent the lightning strike that will set everything on fire rather than cutting down the forest.
And it's such a great analogy. Share your YouTube channel because I want everyone to, of course, like this video, but also subscribe to your channel as well. And you're putting up new content every week.
Yeah, after you have liked and subscribed to Kim's channel at The Way to My Heart, you can find me at Lily Johnston MD, LILYJOHNSTON MD, like medical doctor, at YouTube.
Yeah, it's fantastic. She puts out some great stuff. And I think she has a really great producer too, Joshua.
We sure do.
So, we've given a lot of information. We started off talking about this one-step foods and, keying off of what they're offering. And I do think that what they're doing, it's above board, right? This doctor is
Absolutely.
trying to help, and they do have some research behind it, but it doesn't mean it's right for everyone. And I want to give some key takeaways and some conversation starters for those patients that have joined in who may have said, oh my gosh, I just saw this on my phone, this one-step foods. How do they have that discussion with their doctor?
So I think the first step is to understand, where are you in the spectrum of disease? Are you somebody who is in my surgical practice coming to me because you have a non-healing wound on your foot and we have to talk about your bypass and your stents? At which point, it's an adjunct to the medication therapy that I would recommend to stop the fire that is raging in those arteries, because our first priority is to save your leg and get that wound to heal. And we should explore all of the tools in our arsenal to do that. Or are you coming to my metabolic practice because you have a strong family history of heart events and you want to be sure that you don't end up like your grandfather and your father? That's the case, and you're in reasonable metabolic health and there's no plaque in your arteries yet, but your LDL-C is elevated and you want to talk about how to manage that. Sure, one-step foods would be one option. And in the world of supplements, we have a randomized controlled trial that demonstrates biomarkers changing, and that is really strong evidence for a supplement. We could also break that down into its component parts and say, what do we think is really causing that reduction? And we would probably come to the conclusion that it is the soluble fiber and the phytosterols. And we could incorporate one or both of those separately, individually, if we wanted to,
At a much lower price
strategy that way.
It would be a much lower cost if you did it individually and did it on your own. I mean, all of those ingredients that they have in there are easily recognizable and easy to purchase at your own supermarket or even on Amazon at a lower cost. It's Cyber Monday, so you can get those ingredients at a much lower cost today.
No doubt.
Fantastic. Thank you so much, Dr. Johnston. Again, we really appreciate your time. Thank you for being here, and especially so last minute and on a very important topic. We know everybody, people don't like to be on medication, but sometimes you got to do what you got to do in order to live a better quality of life. But this is definitely something you can do on your own to become a better partner in care, not only with your medication, but also with great foods, whether they're packaged with one-step foods or getting them on your own, talking to your doctor about whether plant sterols are right for you, talking to them about the inflammation in your arteries, because you don't want to be on plant sterols, as Dr. Johnston was saying, if you have a lot of inflammation in your arteries. And that is one of the biggest bases for these particular foods at this organization, but also the soluble fiber. You can get the psyllium husk, right there on Amazon. That's in Metamucil. You can buy the nuts and seeds, the sunflower seeds, the walnuts, the almonds, and incorporate those into your diet. So a lot of things that you could do. Oh, the chia seeds and the flax seeds too. So a lot of things that you can do on your own without spending $125 a month. At least that's the starter pack. I don't know where it goes
public
from
service
there.
announcement. I think there's been some concern recently about lead levels in psyllium. So I think there's a Consumer Reports article that was written, or there's probably some more information online. I'm sure somebody on YouTube has reviewed these, but double check about your lead content in psyllium before buying just the cheapest one you can find online.
Yep, and I think that's with any supplements. I've been looking across the board at a lot of the different powdered supplements from the proteins and such, and they're having an issue across the board. So definitely check into that, check into the reports that are out there, and make sure you have the best quality product for you, or it could do you more harm than good. Thank you so much, everyone, for joining us. Thank you, Dr. Johnston. We really appreciate you. Again, make sure to like this video, subscribe to our channel, but also Dr. Lily Johnston's channel as well, Lily Johnston MD. Make sure to check that out because she has some new great content every single week.
Thank you, Kim. Happy to be here as always.